We have established within the European Organization for Research and Treatment of Cancer a task force, Cancer in the Elderly, which I was chairman in the past, and Hans Wildiers is the current chairman, and he asked me to take his position within this meeting to present our approach to the older cancer patients and report on our achievements and recommendations. I will talk about decision-making in elderly cancer patients, on geriatric assessment in the elderly cancer patients, on endpoint and clinical trials, and of the current research strategy. Just one slide to demonstrate you the need to talk about the elderly cancer patients compared to the younger cancer patients separate. These are Eurocare 4 data reporting the 5 years survival rate of older and younger patients with cancer, men and women. And you see that the 5 years result improved over the years, but the gap between the both age groups is increasing. So the improvements in care for cancer patients are mainly restricted to younger patients and not to the old patients. When we make clinical decisions in old cancer patients, we have two major problems we have to solve. When we don't treat them, we treat them less aggressive, we have the lost chance of cure, the lost chance of prolongation of survival, or the lost chance of symptom control. If we treat them too aggressive, we toxify the natural course, and we result in therapy-associated mortality, morbidity, and compromised quality of life. When we make decisions in elderly cancer patients, we have to look on the cancer, and oncologists are quite good and established well-known frameworks how to decide on cancer characteristics, grading, stage, receptor status, and so on. We have to look on the patients, and I will come to that topic again, and we have to look which kind of therapy do we apply. Cancer treatment is quite toxic, but it differs very much. So on the one hand, it's allogeneic bone marrow transplantation. At the other end, it's hormone therapy. And in between is a whole variety of different treatments with increasing or decreasing toxicity rates. Allogeneic bone marrow transplantation is so toxic that those specialized in bone marrow transplantation consider patients as old when they're 60 years or older. For induction of chemotherapy, those who are involved consider patients above the age of 70 as old. So it's not only the patient, it's the kind of therapy you apply as well, which let you consider the patients as old or not. And we have to take into account which aim has our treatment. Do we have a curative treatment approach? Is it curative itself, or is it curative as an adjuvant therapy in addition to other treatments? Does it prolong survival without the disease? Or are we in the non-curative or palliative approach? And is our aim to prolong survival with the disease, or to prolong the time without symptoms or deterioration of health-related quality of life? Or is our aim to improve symptoms or health-related quality of life? And finally, and all patients will come to this point, how can we enable the patient to have a dying in dignity? Geriatric medicine tells us that there are a whole number of instruments to better describe patients' characteristics independent of advanced age. Functional status, depression, dementia, mobility, and I will not go into details. We transfer these instruments to the oncology setting. And what we can tell now is the geriatric assessment is able to detect changes missed by routine workup of the patients. Those changes are of prognostic importance for survival, toxicity, and health-related quality of life, independent of the age of the patient. We know that the knowledge of the changes can result in changed treatment recommendations. But so far, we have no RCT demonstrating that CGA-based therapy improves outcome. We summarized from the EORTC Task Force Elderly the current recommendations, and there are other from the International Society of Geriatric Oncology as well, how to approach the older cancer patients, and questionnaires and instruments to use for to characterize the patients. We see that we still have to face a lot of problems. First of all, bottlenecks in the development of clinical trials in elderly. There are bottlenecks regarding the medical community. And this is, for example, the poor collaboration with geriatric medicine. There are bottlenecks regarding clinical trial methodology issues. Do we just have to open the upper age limit of clinical trials, or do we have to have specific trials for the elderly? What are the appropriate endpoints for elderly cancer patients? How do we integrate geriatric assessment in the trial, in a multi-center trial, for example? How do we include biomarkers of aging? We have a lot of infrastructural limitations on the local, national, and international level. I won't address in details. We have an inadequate regulatory framework, and we sit here together to improve this. And we have a somehow limited interest of the industry. They like to have homogeneous study populations, and we all know that old cancer patients are very heterogeneous populations. Regarding endpoints of clinical trials in older cancer patients, classical endpoints are inadequate alone. Overall survival, progression-free survival. But what are better endpoints? One example from the Focus 2 trial, which was already mentioned this morning, they introduced as an endpoint the overall treatment utility and had 3 different categories: good, intermediate, and poor overall treatment utility. And they defined no clinical or radiological evidence of disease progression and no major negative treatment effects in terms of toxicity or patient's acceptability as good over your all treatment utility. This is one example which, in my point of view, can still be improved, but it's better than others used in the past. Or therapeutic success. It's a combination of activity, toxicity, and compliance. Other endpoints are health-related quality of life, or quality of adjusted survival, the acute twist approach, or, which I consider very important in old patients and old cancer patients especially, the preservation of functional capacity of their independence. If you ask old patients what is most important for them, it's to maintain their independence. But we haven't addressed this endpoint in clinical trials. So far, there's one example from France from a phase 2 trial. And we have to develop different treatment strategies. Do we have treatment regimen trials where we compare treatment A versus treatment B? Or do we have strategic trials where we compare no therapy versus therapy? For example, adjuvant chemotherapy versus no adjuvant chemotherapy. But the CARTHA trial is an example, but the trial had been closed due to poor recruitment in the past. Do we have to have special trials, specific trials for old cancer patients? Or do we have just to open the clinical trials and to have no upper age limit? There's one analysis regarding this topic from the US, and they analyzed 4 trials in advanced non-small cell lung cancer, and they could demonstrate that the recruitment of older cancer patients is better if you have specific trials for the old cancer patients and not just open the trial by not having an upper age limit. The optimum is a combination of both and the inclusion of a prospective registered trial, including a geriatric assessment, and I will demonstrate this later. We had a workshop from the EORTC Task Force Elderly together with other European research groups for older cancer patients and came up with a proposal, and I summarize this proposal. We have the proposal that an obligatory reporting of age-related subgroup analysis, including number of patients, efficacy and toxicity data, if possible, pooled age analysis is mandatory, that the obligatory post-marketing studies should be mandatory, because the license of a drug for younger patients should not be postponed by lacking data for older patients. Obligatory inclusion of a minimal data set for geriatric patients in registrations trials and post-marketing trials. And we had a long debate which kind of assessment to include. And this is only a minimum data set. Much would be better. We recommended to include the G8 questions. It's a recent publication in the Annals of Oncology, mainly derived from the mini-nutritional assessment. We are recommended to include the instrumental activities of daily living for functional status, and to include the Charlson Comorbidity Scale and the social situation of the patients. And this is my last slide. All patients above a certain age or should be included in a prospective registry. And we have to judge the patient's fitness and come from gut feeling in the formation of the 3 groups to assessment-based decision-making. The first group of fit patients with good organ function, good functional status, good life expectancy, only very few comorbidities, and low risk of toxicity. We can use classical endpoints for this type of patients and can apply standard treatment, or in clinical trials, standard treatment to new approaches. And we have a group of compromised patients with reduced organ function, reduced functional status, moderate impairment on life expectancy, some comorbidity, and a little increase in some increase in toxicity. A group of slow-go patients, they deserve special endpoint and treatment protocols. And a third group of patients, those who are really frail with a severe reduction in organ function, severe impairment of functional status, severe life compromise in life expectancy, and severe comorbidities and toxicity. They might profit, or those might be the population for a primary palliative care approach. Thank you very much.
Thank you, Dr. Wedding. We have time for a couple of questions, if any. Yes?
Jean-Pierre Bains from the European Union Geriatric Medicine Society. Thank you for this presentation. You said there are no randomized clinical studies about the utility of geriatric assessment. I can tell you that the comprehensive geriatric assessment is now approved by the Cochrane Library as a major positive endpoint. So I think we have to introduce really in all real geriatric patients this comprehensive geriatric assessment, it's really very important. Do not forget that when you have a very old cancer patient, you will have also always comorbidities. So you have to look not only to the instruments of the comprehensive geriatric assessment, but you need also the whole expertise of the geriatric multidisciplinary team. And I think that's very important. So you say also that you are not happy because of the collaboration with the geriatricians. Well, I think that geriatric medicine is at this moment really a partner to work together with the oncologist for this point.
This is true, I know. And most of the oncologists would be happy if they have a geriatrician available in their area, in their practice, in their hospital. They could collaborate with. And within Europe, there are countries with a very good geriatric medicine established and others with very poor established geriatric medicine. This is one point. The other point is, due to the toxicity of the treatment, oncologists see patients and consider them as old patients, where a geriatrician would say, oh, I think this is not a really, this is an old patient, but this is not a geriatric patient.
Yes, Elisabeth?
I think this is a very good example, what we observe, that the border in between disciplines are more and more going away. And we have, again, in Berlin, a huge study which is called Peratex. I think you know this. And we also do this together with the University of Munich with oncologists. And we look for all kinds of different tumors. And we check the functionality and a lot of parameters also like here. And we hope that when we collect all these data beside laboratory findings of oncology patients, all the functional things and the other treatment for the comorbidity and so on, that we can come up with better decisions or decision making and do it in a consensus. But I think this has also something to do with ourselves, that we have to learn that this is a win-win situation and this is not running by competition.
Yeah, and a win-win situation on both sides. Both sides have to learn, the oncologists and those specialized in geriatric medicine.
Yes.
From your experience and in the context of the perspective to have an holistic approach, do you think that we need to rethink the endpoints in this case? I mean, the challenge is the frailty of the person, and maybe to include new endpoint. I mean, patient-related outcomes, and to take into account also the carers.
Yes.
And to rethink and to redefine, I think, because it's somewhere your conclusion. And to integrate, of course, in the assessment, the comprehensive geriatric assessment, which is only a multidisciplinary approach. You don't need to be a specialist to make this.
I think oncologists are not very used to this kind of approach. So we have the one solution that they have to integrate with the geriatric medicine. But what do they do if they don't have a geriatric medicine around? And the first step is to introduce geriatric assessment as a diagnostic tool to make better prognosis in the patient and to decide which treatment should be appropriate for them. And for example, if you decide on adjuvant therapy, you don't have frail patients, but you have to decide whether they will benefit from the addition of chemotherapy after a curative operation, or whether the comorbidity is a leading cause of death. and they won't benefit.
Life expectancy and all these parameters are important, but what we learned about 20 years of Berlin Aging Study number 1 was, in the beginning, all the participants, the more than 2,000, were quite in good shape. But during the 20 years, they came up with more and more diseases which we had to treat. But we always had certain parameters about quality of life and subjective health. And objective health and subjective health, they go like this. So when there was an old lady of, let's say, 89 or 85 years, and she had tremendous diagnosis, and we thought, oh, wow, she is so ill, poor lady. And then we saw the follow-up in between the 20 years of her subjective health and her well-being parameters. They become better and better. And we were wondering, why that? We learned that these patients, they think, oh, when I compare myself, I'm now 85. How, for the year of 85, I'm quite good in shape. And even when I compare this with the lady in the neighborhood, she is 70-something, and she cannot leave the bed anymore, and this and that. And I think this is also a parameter that we doctors don't have in our space.
Okay, next question. We have time for another last question. No? Yes?
Just to remind that comprehensive geriatric assessment provides also, in the long follow-up, in the long run, what are called the universal health outcomes, because we can't rely, especially in oncology, with the traditional outcomes, morbidity and mortality. Who cares? We need universal health outcomes, which are the outcomes related to the daily life, to the quality of life of these people. And that's the end of the game.